Hello, my name is Logan Eckler, and I will be discussing the use of supplemental oxygen as a therapy for acute coronary syndrome patients. So, the research question I present is, does the use of supplemental oxygen therapies increase the risk of adverse outcome rates, including death, recurrent ACS event, recurrent hospitalization, arrhythmia, or the progression or onset of heart failure for the adult normoxemic acute coronary syndrome patient when compared to room air therapy only? So, to give a little bit of background, acute coronary syndrome, shortened to ACS, is a combination of similar specific medical diagnoses, most notably myocardial infarction, colloquially known as a heart attack, and unstable angina. Patients with this syndrome have reduced perfusion to the heart muscle. This is called ischemia, and when not addressed quickly and correctly, may result in the death of that cardiac tissue called infarction. Given the disease is caused by an underlying lack of oxygenated blood, oxygen therapy was integral to the care of ACS for over 100 years, and has only diminished in the last 10 years or so. Even as research over the last 50 years has shown the lack of benefits and potential harms of unnecessary oxygen therapy, healthcare providers, institutions, and regulating bodies continue to authorize and order oxygen as a first-line treatment of ACS even to this day. So I present 5 studies within the last 6 years, including 2 systematic reviews as well as 3 prospective studies. All studies used random sampling to assign participants to their experimental and control groups, and 2 of the 3 prospective studies used single blinding. Kushnud et al. 2017 actually used double blinding. All studies compared supplemental oxygen at a defined rate, varying from 6 liters per minute with humidified nasal cannula to 10 liters per minute by humidified non-rebreather mask. The dependent variables and subsequent outcomes varied by each study, with 4 studies measuring all-cause mortality, 2 measuring the recurrence of an ACS event, 1 measuring rehospitalization rate, 1 measuring the rate of new onset arrhythmia, and 1 measuring the mean ejection fraction of the 2 experimental groups. The vast majority of findings among the groups were not significant. The 2 and only significant findings come from Stubb et al. 2015 and concern the 6-month rates of recurrent myocardial infarction and 6-month rate of recurrent or new onset dysrhythmia. For both of these, the oxygen therapy group is significantly higher than the room air group. Stubb et al. Also had the largest discrepancy in the all-cause mortality of the presented studies. And as such, Stubb et al.'s findings are inconsistent with the other outcomes evaluated, including those systematic reviews, and should be investigated further before implemented. So moving down here, this is a representation of the all-cause mortality during hospitalization at 1 month following discharge and at 1 year following discharge. The data comes from Seprevend and the Hoffman et al. Studies. Mortality increases over time as expected, and given the limitation of the available data, it is impossible for me to know or display the true sampling or relative errors of these metrics. I can say is that all of the graphed findings are not significantly different. So moving out to implications and barriers for the nurse. The nursing implications of these findings show little significant difference and therefore little benefit or risk to the use of supplemental oxygen in the normoxemic ACS patient. One study presents 2 significantly worse outcomes for oxygen therapy. To incorporate the evidence presented here, the nurse should advocate for an evaluation of clinical practice guidelines and or the institutional policies which authorize or order the use of supplemental oxygen for ACS patients without considering the patient's individual oxygenation status. I would also like to restate and or reiterate that all of these findings and all of these studies apply only to those patients who are at baseline normoxemic and should not be used when treating or evaluating hypoxic patients, dyspneic patients, or those requiring more complex respiratory management. Some of the potential barriers to the implementation of these findings include the historic use of oxygen therapy. As I said at the beginning, it's a well-instantiated practice within the healthcare community, and as such, there may be resistance to change from organizations or individuals that do not have an efficient model for the implementation of evidence-based practice. This resistance is only further exacerbated by the perceived potential risk of morbidity and mortality associated with such a high noticeable and high urgency disease and disease process such as ACS. As such, providers and nurses may choose to err on the side of perceived caution when assessing a patient's oxygenation status. This would need to be addressed, if needed, by intra-organizational education and evaluation metrics based on the needs of such organizations or facilities. So in conclusion, going back to the PICO question at hand, Does oxygen therapy increase the rate of adverse effects? The evidence says yes, but more research should be performed to know for sure and increase confidence. In any event, the absence of oxygen therapy in the normoxemic ACS patient is shown in this data to be safe. And if given the option between giving a drug and not giving a drug without any outlined potential benefits, the drug in question, oxygen, should be avoided for this patient population.